I'll do so with a roll call vote alphabetically, by town, if you can state your name and just that you're present. So starting with Dover,
Kay Peterson, present.
and then Medfield
Kathy Thompson, present.
and Needham
Ed Cosgrove, present.
and Sherburne.
Darrell Beardsley, present.
Excellent. So, calling the meeting to order, there is no one from the public present, so we can dispense with public comment. And we have no minutes from our meeting from last week yet, so those will come, so I'm already behind, like I said, I wasn't gonna do that, but we're meeting, yeah, within a week, so, for staff reports, there really isn't any new information for y'all since we met. Which moves us then to the main topic, which is work plan and budget, which I sent to everyone, and I see Carol. Hi, Carol, thanks for joining. We were talking here briefly before we got started. Everyone received my emails and maybe was able to read some of it. So as a reminder, what we're doing is we're setting our budget for the upcoming fiscal year, which is July 1 through June 30. And the budget is based on the $325,000 that we get from Office of Local and Regional Health. And because we get those dollars, there are things we need to do in exchange. They are things that will benefit the shared services arrangement. We get to choose from a menu that they provide to us. I sent that menu out to you all and just highlighted the things that I thought were in line with what we've all talked about during strategic planning, during our meetings and so forth. I may be wrong, and that's what I just wanted to start the conversation. The requirements for those, we have to, so there's a first section, there's a bunch of things that we have to do that are non-negotiable, grant management and making sure that everyone signs on the grant every year and reporting timelines and so forth. And then we have to have 2 performance objectives, 2 sustainability objectives, and we can have 0 or, we could have as many as we wanted, elective objectives. Within each objective, you need to have a minimum of 3 activities. The thinking is that if you just pick one, then it's not really an objective. So that's part of what goes into looking at them and saying, okay, there are 3 or more things that we could do in this thing. And I think that's it. So we'll discuss this today, get your feedback, hopefully approval or approval changes. And then Jen and I have some more work to do to enter all the information into Smartsheet, which I'm not showing you all, because it's complex. We'll submit it in Smartsheet. It will go to our Office of Local and Regional Health. They will review, ask questions, approve, let us know we're approved, and then that will be our work that we will be doing for the entire year. I do have. Follow up. Follow on this, does anybody have any questions about that summary that I just offered? Or shall we just dive into work plan? Okay, I don't see, I see Kay nodding yes, I don't see anybody raising their hand, so let's talk about work plan. So if you can pull that up, Jen. So page one is a summary of, kind of the instructions, that I just tried to summarize for you. And then page two,
Sorry.
it's okay. Yeah, no, take it, take, there we go. So, and then if you scroll down to page two, that's where the required objectives start. So, and you can see I highlighted everything because we don't have a choice. All of those things are things that we have to do. Required objectives, and that continues for page three. And page. That's 3 and 4. So go,
It's just slow as a delay.
got it. And then 4. Right, so now on 4, these are the sustainability objectives. These are the ones that are,
Do you mean page 4 or item 4?
no, page 4, sorry. So I can make,
Got it.
do
No,
things
no.
like highlight the document, but it's not my document, so I wanted to have page numbers. It makes me crazy to not have page numbers personally. But so we're on, so now we have sustainability objectives, and there are 5 choices, and I chose the first 2. And I don't know if anyone has interest in the other objectives. I thought that the first 2 made sense for us. Particularly, we talked about trying to do communication and engaging more with folks in the community. Understanding who are other folks that are interested in the work that we're doing or potential partners. So to me, that seemed to make sense as some activities for us to engage in. And then the improved sharing of resources, in some regard, those are things we're already doing. And I wanted us to get credit for that. And then looking at the other pieces, I didn't see others on options 3, 4, and 5 that I thought would be achievable or reasonable for us. But that's just my first thought. Any comment or question on 3, 4, or 5, or whether 1 and 2 make sense? And we can't see all of you on the
Yeah,
screen right now. It's okay. So if anybody has anybody participating remotely has a question, sing out.
I do.
Sorry.
Thank you.
Oh. Yep, go.
Thank you, Jen and Carrie, for all these emails. I'm sorry, Miss, as the backup,
To say
you
that.
prepared. No, you prepared a lot of work, and
Thank you.
Kathy anchors us, thankfully.
Good job.
I just wanted to ask, are we going to discuss the budget, or is that done?
Yes.
That was last, okay.
Yes.
So right now we're talking about this. One of the things that we're grateful for is the fact that the leadership of this group enables Kathy and I to share with our board during our meetings what's happening at the state level, going on to the OLRH calls, et cetera. One of the things that I feel I would like to see this group do, I think it's awareness in number 1, is be able to communicate collectively on what's going on related to health, to be able to give us something or say DPH release this, and that way it gives us agency with our town manager and people that are making decisions right yet on what's on the website. Now, Kathy probably told you the town hired a part-time nurse. It's important, I feel, for her to also be able to hear from us and to hear from our board and this regional group that this is important communication to post on the website or to shoot out in the text alerts from Medfield because the decisions are made top down. So number one is the communication. I don't know if there's any person or structure that even DPH has created, that these are appropriate recent health communications updates that your towns as members of shared services should shoot out. And then the last thing I have is that in Medfield, this group is our lifeline for us to advocating for operating budget funds to improve our capacity. So I feel number 3A, to identify our areas of strength and in areas of improvement. And then the other is how much each municipality is actually participating in the shared services. And I say that to be able, again, to advocate for us through our operating budget, especially as funds are going to be tight. So have our community understand, and I know that's number one, and also the leadership. So I said a lot. The first one's about health communications, and this group validating them and us being able to advocate for them to go out. And the last in number 3 is for us to be able to show what we need to build in regard to services. And I know this information's always been processed together and Needham's in there and makes our numbers look better. And so thank you for letting me talk.
Thanks, Carol. And you know what? I have to correct myself and say that I lied. I said I chose 2 on the sustainability. I actually chose 3, with the thought that there might be some discussion. Thank you. So Carol, what you're saying is you're in favor of sustainability. You're in favor of the objectives that were the objective 1. So communication and engagement, and those things. And that's great to hear. And then if I understood you right, you were interested in, on item 3, expanded sharing of internal services. You were interested particularly in A and B. Is that right? Or did I miss?
Yes, in the past, I expect our engagement in opportunities and services in Medfield is going to increase. Christine, our town manager, really has gone above and beyond and restructured her department for us. But we go to the select board 4 times a year, and I feel it's important for our Board of Health to be able to share with our select board what we're doing to bring these services into Medfield and how we can grow and increase that.
Yeah, no, that's great. I just want to make sure that I caught everything that you're saying. Okay, I don't know if anybody else has come. Kay has something, yeah.
I want to respond to what Carol was saying,
Yeah.
because I think it's very important.
Yeah.
As you were talking, Carol, I was flipping through this tome that Carrie sent us, and but I don't see anything that addresses what one of the takeaways from what Carol said, which is how do we enhance communication from the State Department of Public Health to our communities about public health, active public health problems in the state. And this is particularly problematic now that the CDC is not a reliable resource for us. Does this make sense to people? I feel as if even I don't even feel as if the state is to some extent stepping up, but I feel so. Let's talk about measles, for instance. We've heard that there was an active case of measles walking through various places in the Boston area recently. But there's no centralized, yet, I expect we'll see that, not enough focus on, you local boards of health need to be getting out information about this. Until we have that, well, to the extent that we have that, that needs to be clearly funneled to us and then pushed out to, not only to our residents, but to our select boards and others. I think we need to focus on a very targeted way of disseminating that information. And that will help us not only manage the active public health problem, but help a community like Medfield, where the value of local public health isn't particularly recognized. It'll help that community, both residents and board members, to understand that yes, this counts. And it's an issue everywhere. We happen in Dover right now to have a select board that I think would be viewed as supportive of public health, but just a few years ago we didn't, and this could be any of us at any time. We're one election away from having animosity toward public health in our town governments. Well, I think I may come back to this, but I think this is really important. And and to get back to what I was saying about what you sent us, I was just scanning this, and I don't really see how that precise objective fits in, where it fits in best. It's not, it is communication and engagement. It is communicable disease related, but it's not explicitly addressed.
Yeah, I think that's a helpful observation. I do think that there is an expectation that shared services staff are the ones who are sort of the mediators of the information.
Yeah.
So the things we have for disease control, for example, the participating in the weekly Haven calls and the like we see later on, those are mechanisms for getting information. And then what's implied, I think what's implied, what you're pointing out is there's sort of an implied that information would be shared. And that it would be better to add, and we can add a custom activity, we can add a custom activity on either, I think it would be better under communication and engagement, because we're talking about not just disease control, we're talking about environmental health issues. So we can add in to communication and engagement, working on dissemination, I'm just gonna make up words, dissemination of timely info, re-emerging public health issues. From the state, from state authorities to all jurisdictions, state authorities to all jurisdictions. Does that sound right? Did I capture kind of what you're after?
Yeah, and
It's great.
I mean,
Thank you.
the question is, if the state authority, let's say the state is not addressing something, I mean, you could imagine that our nursing group would play a very important role in this. And that they might decide that they're very concerned about issue X, and there's nothing coming from the state, and there's nothing coming from the CDC yet, and they want to get out ahead of it. And they might come to this body and say, we think our shared services group should be promoting information about issue X throughout our towns, and that would give it some authority. It wouldn't just be the Medfield nurse, the Dover nurse, or whatever. This body, which would have some authority, I think, to speak.
Okay. So adding to dissemination would be, sort of identification of for information.
Yeah.
And it's kind of both gathering and, sharing, right? So, I mean, it's in regularly, like the identification of hot topics. But that's that.
Am I out over my skis on this, or?
No, agreed. Okay, do others have, oh, Daryl's raising her thumb up there for us. Thanks, Daryl.
Look, I never saw you
Like
do that
yeah,
before.
I know. It's animated, it's good, it's letting us know it's there. Yeah, and I think you pointed out something important that's kind of is this makes implied, and it ought not be. I think that, we ought to make it explicit, so I can add, and I'm making handwritten notes here, and we'll rely on the recording too if I have any, options. But
Does the nurse consultant program have input into this too? I mean, there's one thing for shared services, but I would look to that nurse consultant too for.
so they can be a resource along with the state is how I look at it. They're not, they're a resource to shared services that we would include. So when you say information from the state or information gathering, the state, that would include the nurse consultant. In my mind, that includes the nurse consultant program. Does that make sense to you? Does that track with your?
I guess I see it as distinct.
Can you
State.
From
talk
the
more
state.
about that?
Because they're under the purview of UMass.
So the state does have contracted resources, so MHOA has a subject matter expert program, which we avail ourselves a little bit, and that's funded by the state, they're employed by MHOA. I think the nurse consultants, I think it is a little bit of a weird line, they're clearly funded by the state and work very closely with ORH,
Yes.
but there is some independence because they are UMass employees and so I think we should make sure that we
I mean,
carve out some of,
Yeah.
or take advantage of the technical assistance that's offered.
yeah, because they are, I see them as very embedded in the state, but
Yeah.
their employer is UMass, but they're the host agency, so, okay.
And I think they're still finding their way a little bit,
Yeah.
in terms of, are they helping with training? Yes. Are they helping with sort of technical assistance for shared service nurses? Yes. And are they trying to help provide actual technical assistance for all of public health nurses? Yes. So they're sort of trying to move forward on 3 paths.
Yep.
But it's still
They're very new,
still
so,
very.
their scope is a little narrow, that's the, that, I think that's what we're trying to, yes, thanks. So Daryl's got her hand up and so does Carol. Daryl?
Okay, so I guess as I'm reading this, I like the details that are being brought up about things for us to look at. As I read some of these, I assume they're fairly boilerplate, these options and activities. Because I can find a way to have what we've been talking about fit into a number of places in here under the heading of details associated with them. So I guess I'm just saying that I'm okay with the selections because there's a lot of overlap, I feel, from category to category or objective to objective in the activities.
Right, Daryl, I
Right.
mean, it's
Depends on,
boilerplate. Sorry,
Oh, no, go ahead. What were you saying?
you're correct. So this document that I shared was created by the state for, all 51 shared service arrangements. So everyone is choosing off the same menu. Yeah, I mean, so I understand what you're saying, that you see you see these things as reflected, but maybe not as explicitly as we would like.
right, but
So
I
it
think
sounds
we
like
can
you're,
sit,
you're endorsing these additions, but saying, you know, that they're kind of alluded to in different sections. Is that right?
yes, yes.
So are we allowed to customize this at all or not?
So we can create a custom objective, which I just did. We can't create all custom objectives.
We have to adopt
We
these.
have to, basically, these are the places we start, and then we need to make a case if we need something different, then, yeah. we can make a case. I think that this additional one in communication and engagement makes a lot of sense. If others are in favor too. Carol, I see your hand up.
A quick question. We depended a lot on the Academic Public Health Corps. I believe they got disbanded, but I don't know if MHOA has any kind of this program. Not needed, right, to reinvent the wheel. And I'm sorry if I don't know that answer.
So, I think MHOA has stood up and created information based on specific instances, and I'm looking at Tim as MHOA.
Tim was looking down, so he didn't get the first half of the question, so before I agree, can you say it again?
Carol's asking about, she thought the academic public health, it used to be the academic public health board that provided, resources, this.
Yep.
But you're right, Carol, it was disbanded and is different, but,
So now it is the Pathways to Public Health, which is working to get community college students to do, in addition to their community college studies, a series of professional trainings and work placement at a health department in sort of not a full environmental health agent, but an inspector level.
right,
So unfortunately, the Academic Public Health Corps and the sort of, for lack of a better word, like short-term internship that you could get multiple times is gone.
right. And the communications work that they did kind of ad hoc, it has not been continued in any new grants. Okay, right. So, yeah, they were a great resource, for during COVID, but no, and I think one of the things that we are, doing, you know, we've talked about the need to know how to use Canva and have communications training, and that contract is actually out with the vendor right now, so we'll be able to work on that, we'll bring back the schedule and time in for you all. And they'll be doing training in each community with staff on how to use Canva, and they will also create some templates for us so that there is, a consistent branding, a consistent, you know, format, and kind of, you know, what some communication pieces might be. So we have some other help that will make this possible, but what this objective is doing is saying, this is one of the things that we really want to focus on this year. We want to focus staff time and energy from the shared services level of making sure that there is communication happening, that increases awareness of shared services. I think increasing awareness would be, let's tell you about measles, right? It's not just, let's tell you about shared services. It's, let's tell you about measles. Let's tell you about the inspection services that we have. Let's tell you about how we are, accessing training for our public health staff. It's, I know it says shared services, but I see it as what are the capabilities of what we're doing for elevating public health. So, makes sense? Okay. Carol,
Yes. So I know I can be persistent. I see it as two things. Can you tell me that was the interpretation? One is to promote our connection, the work of the region, the objectives, encourage our municipalities to pause and be aware, and then understand what the structures and operations are and goals. And then to me, the other missing piece and the grant that I've managed through DPH with 4 towns, we've understood the benefit is not to, there's certain structures we all do in public health or prevention. How can my town, Medfield, tie into state-approved communication? Because I agree, we may not want to be tying into CDC-approved communication. I'd rather have what Dr. Katie tells us. Anyway, perhaps it's OLRH that is putting out opportunities where you can go on and pull up a DPH-approved communication on whatever issue that we in our individual towns might feel is important. So I'm hearing that you're having Canva training. Every town is going to try to be consistent and look consistent. What we've talked about in our board is having agency with the communication so we don't have to rewrite it, have it approved. It comes from DPH. It's, supported through best practice and evidence, and then we can shoot it out to our towns on health issues, vaccines, all the things that are under the purview, environmental health, PFAS. So to me, I see it as 2 different things: shared services, communication, awareness, and then public health program updates, best practice communication. And maybe if APHC isn't doing this and MHOA has a different great goal, maybe it's OLRH. Maybe something Sam and the group is putting together.
So I think we're saying the same things, but I'm not entirely sure because so Jen Gagarin will be pulling together a working group for the nurses. And we continue to have the environmental health working group. And the sources of information that both of those sections access come from Office of Local and Regional Health. It's not necessarily going to be a flyer though. It might be a slide. It might be a slide from a weekly call, or it might be a posting to the website, and there will have to be some taking that language and putting it into a flyer format that you can distribute. The state is definitely not engaging they're not creating a communications arm either, right? They do some, but not all. But that's the work, that's part of the work of like staff, that's their work anyways, is what's the state saying? What is what are the nurse consultants saying? What does Biddle say? And that's staff's responsibility is to access that information and then figure out how to communicate it. We're gonna support them and emphasize that, I guess. Enable, coordinate, right? We're gonna make it easier because we know that in every town, everybody's got 20 things to do every day, and they're able to chase down the information maybe, but they're not able to convert it into a document, or they're not able to test it with somebody else. Does this make sense? So that's what I think that's what I think we're talking about, and I think that addresses what you're asking about, Carol. No.
I'm going to stop after this comment. We are all at different levels of capacity, and when something's urgent or pending that we feel our community should know, with our nurse who's 19 and a half hours a week and our other staff not being there yet, and the fact that these are standard communications that I think we shouldn't have to edit and reinvent other than drop our logo on next to the public health thing. So, yeah,
So I think maybe we can take this, maybe, I would love to see some examples of what you're talking about in the standard communications.
Yep.
I think we're on the same page.
Yes.
And I think, you know, maybe it's hard for you to envision, but knowing how Dale works with Gen Gathering, the same thing would be the expectation with the Medfield nurse, right? There's regular communication, and same thing with Ginny here in Needham. There's regular communication every day, all the time, about what's happening, what are active cases, what do you think I should do this, and, you know, is this the way to handle it? So what we're doing is sort of saying, let's put extra attention on how do we communicate all of this work that we know happens, and make sure that we push it out to folks in the communities, and shared services can help with that. So building capacity at shared services level and at the local level. That's how I think, and I think it's the same thing with environmental health. You know, it's a, oh, we've got a complicated thing. I'm talking to my colleague, I'll check to Cy. Is that accurate? I'm looking at you, Jay. Am I putting words in your mouth, Jason?
No, absolutely. That's just something we do naturally. You know, you pick up the phone, you call Cy, you bounce something off of him.
Yep.
You call Mark in Sherborne.
Yep.
Same idea. Mark, I have a septic question. You're the expert.
Yep.
You know.
Yep. So people are accessing the resources. We're trying to take the next step with this objective and figure out how do we do good communication about that work. And that's what I think shared services is. It's that work. It's not us, you know, it's the work. But so Carol, maybe you could email me and send in a document with the like some of the standard resources you're thinking of, and I'm sure that we're probably in the same place. Yes, no, maybe?
Thank you.
She's smiling. We'll get there. Okay. So I think we're all agreed on this. So, and we have a few more. And we still have to do budget too. We're agreed that on the value of this objective 1, I have a custom objective to add, which is about identification of the need for information gathering and sharing among the communities, accessing state and state-funded resources, dissemination of timely information to the public regarding emerging public health issues, and that we want to, you know, that we're not recreating the wheel, that we're leveraging existing information. So that would be activity 4 that I will add to the list for that first objective. Is that, if that's accurate, I'd love to move on to talking about objective 2 and objective 4, I think was the other one that I highlighted as possible application for us. As I said, item 2, that is, you know, in some way that is stuff that we're already doing, and I do want us to get credit for it. Jen, can you move next page so we can see the other one? Thanks. So, and then objective 4 is about community partnership development, which I think is kind of part and parcel. It goes along with the communications work. I'm a little hesitant because it is a lot of work, and I don't want to overcommit us. But I'm so curious if people have a preference, or if they like both. They want both chocolate ice cream and vanilla ice cream on the plate. Thoughts? Strong thoughts?
Well, can you give an example of what might be a community partnership?
Sorry, I have to pull it up because I can't read it on that screen. Here. Oh, no. So this is about what it is it's so when they refer to a partner mapping exercise. So identified a bunch of partners in the foundational public health services assessment thing. We said, who else do we work with? We work with the pharmacy for vaccination. We work with, maybe the senior center, council on aging. So we take the information from that resource. And then we'd be talking about, are there gaps? Do we need to find new relationships? And then the next step would be an outreach and engagement strategy. So sort of, how do we build a new relationship? Is there a new partner? And there might not be a new partner, but there might be. And I think this comes up especially when we talk about one of the foundational public health services was maternal child health, and it was, well, wait, we think there are other people taking care of this in town. So that might be a thing of mapping and figuring out, well, who else is taking care of it, and once we've done that, do we know now, yeah, this is a pretty well-covered area, and we don't need to think about adding capacity in our communities. So that would be one example. It might not be maternal child health that we focus on, it might be some other area. Does that make sense? Okay.
I'm thinking like, in that sense, get them while they're young. And so like Nina has youth services, maybe there's a way of partnering somehow with youth services.
Right.
So you make them aware of issues, public health issues, disease issues,
Yeah.
et cetera. When they're
Right.
still in high school.
Right, so, I mean, so this one is like a exploratory, I think this objective with 4 is just that, it's an exploratory thing, figuring out, well, where are there some good are there partners that maybe are working in the areas that are of concern to public health? And what could we do with them? So another one would be like that, like, does it make sense to try and have some education aspect about public health with youth services?
Or you work through the high school, through the high school.
Right.
That's how you get over through the high school.
Recently, I joined the community partnership group at Newton Wellesley. So there's a lot of energy in that group, and interests. And needs that they would rely on public health for, that we can bring to the table to manage capacity at the hospital, education. I have met with BI Needham to their community relations person. So I think that's a big area that can really grow pretty fast.
So it's, I think for me, I'm interested in this for us. I think it's a good offshoot of the communication. I do think like it could, as Gail says, it could grow, and I think the challenge would be trying to keep it maintained so that we're retaining primary focus on the delivery, making sure we can do inspections, we're doing the public health emergency pieces. I don't want to overcommit, but I do think it's important for us to know who else are our public health allies and partners in community. So that was why I chose it. Is this in line with what people think we ought to be working on? Yes.
Yes, I think so.
Okay. All right, so we'll have 3 sustainability objectives, and I'm okay with that. I'm thinking about demands on staff because, as I said, I think that we're already doing a lot of work on item 2, and I just want us to get credit. So, okay, so we're through sustainability, yay. Now we have performance standards, and these are directly related to the capacity assessment requirements, and I chose, we had again 5, and I chose 3 again. The first one is about training opportunities. So this is saying, okay, here's the staff that we have. We know that we have expertise in this area or that area, and what can we do to provide training opportunities to staff to enhance training in other areas. I thought, especially because we have a lot of or will hopefully have newer staff, newer to our communities at least. I thought that this was an important thing to pay attention to. Important for everyone to be aligned on these are the kind of the standards of what everyone ought to have, everyone ought to understand, and these trainings that will inform everyone's work. That's a really important piece to make sure we're all on the same page, especially as you start bringing new staff in. And, we do have an advantage, we have ready access to a training hub, because we also manage one, so they can support that. And I want us to get feedback on the trainings. Are they useful? What trainings do people need, right? Jason might have an idea of this is what we really need. We're not just gonna rely on the data as we scale, and we can take in all sorts of, observations, and we can make sure that everyone on all of the boards of health understands these are the trainings that folks ought to be having, and these are how we're accessing it, and this is how we're maintaining and improving public health in all our communities. So that's my pitch for number 3 and why I chose it. Disease control, we're growing our capacity for public health nursing with the hiring of the public health nurse in Medfield. That's great. I think it's an important underpinning and needs to be, it's kind of continuing work of what Jen has been trying to do this year. And that disease control it's like the bread and butter, right? It's the basic work of public health. So I didn't know how not to pick it. Daryl, I see your hand up.
Okay, I took it down because I figured you were kind of running through things, but I was going to comment on the training. We'll be able to put that through its paces very soon, I hope. We have hired a new administrator, and we will be looking for lots of training for that person.
Wow, congratulations.
Yes, thank you. I'm very
Okay.
excited.
Yeah, all right.
I'll call
so
you
good.
about that.
Good, okay. And great. So, right, so another, endorsement of the need for consistent training, that's something, shared services can, help track, help identify, help you all communicate about. Then the last one is tobacco, because we have talked a lot about wanting to figure out where we are with tobacco. And this seemed like this objective was kind of written for us. It lays out exactly the steps of what we want to do to figure out where is everyone, how can we go about implementing compliance checks, and also lets us, and directs us to talk about, do we want to pursue creating a tobacco collaborative? There will be funding available in FY28, and does it make sense to go that way or continue with individual community setup? So, does anybody, I realize I just rattled off all 3 of them very quickly, but does anybody have questions about any of those? I think there might be one here.
Yeah. Made you think that. Tobacco use prevention, item A, document by August 15th, 2025, how each participating municipality, blah, 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 will conduct retail tobacco inspections and so forth. That includes compliance checks by August 15th, because that's the rub, I think.
Right. So that is a, not a, regulatory requirement, it's a sort of a, what are you doing? They wanna identify baseline
I see.
of what are
We
you
don't
doing?
have to be there by August 15th.
No.
Okay.
They wanna know what you're doing, and then it will enable working with, yeah, no, I know, that's, it will enable, the tobacco program folks to work with us. They'll have a handle on where the different communities, or shared service arrangements that have chosen this objective are. So, yes, no, we don't have to be doing all the things to do that, so. Does that, that, to me, these objectives were actually pretty easy. was there anything on items 1 or 2 that jumped out? People said, oh my gosh, why aren't you choosing that one? Or did I get it right? Staffing needs, I think we are, I think people are clear on what, at least what their current staffing needs are. I wasn't sure that we wanted to dive in this year to a HR assessment. Oh, what are the things that we really need to hire for future? That to me felt like maybe a FY27 objective. Let's get the positions that we have filled for the moment, and then move forward. That was my reasoning in not selecting it. And I thought because we were doing the training piece in sustainability, I thought that that item 2, we didn't have to do that there. Daryl, I see you lit up, but I don't see your hand up. Are you? There's a little green box around you, like you might have something to say. It's okay if you don't. Okay. All right.
Is that
So-
Carol or Daryl? Wasn't me.
Daryl, yes.
Yeah, I don't know why it would have been green. My mic was off. Okay.
All right, so I'm hearing no concerns or objections about the 3 objectives for performance standards that I highlighted on this document. Okay, excellent. So now we move to a huge selection. We have electives. There are 11 to choose from. I did choose 2. There's certainly others that we could do, but if we're going to take on 3 sustainability objectives and 3 performance standards objectives, I really don't want to overburden us and set us up for failure. So I chose items 8 and 9, and that aligns. So 8 is about assessment and surveillance. It aligns with the disease control work. It's the activities that public health nursing are engaged in. And I think it's about doing some planning work and thinking about, well, what populations are there that we want to proactively think about engaging with. And then item 9 is inventory management, and that is something that we have done on the training website. Jen's been very actively involved in it, and I want us to get credit for it, and I want you all to be very aware of how we're doing it and understand what are the resources, both the lending.
Sorry.
Okay, the lending library that the training has, and then kind of what are the things that we don't have. Our budget is tight, right? We have not bought a lot of stuff, but we do have inventory to manage, and it's important to have good practice, and I just wanted us to document that. So those are the 2 that I chose. Were there others that people thought, I really wish we worked on this? So many. Yes, ma'am.
Maybe number 2, I mean, it's part of our goal in Dover anyway, but maybe it's not a widespread enough goal. I mean, Needham has, I assume, great access.
Right.
We need to do that at Dover. The fact that we don't adopt this as a shared goal doesn't mean we're not going to pursue it in Dover.
Right. And that was a question for me, because I know that there is interest in that. So I would, if communities would like, I would take that one on. I've talked with Jen about it already, and she agrees that, based on everyone's desires, it's an area of work that's gonna happen. So Kathy.
Yeah, same in Medfield. I like that goal number 2, that we're always, even before when we had a full-time public health nurse, that was a goal of ours. And then not having one for a bit, that sort of fell by the wayside. So I would very much like that, to use the communicable disease control, especially vaccine access as a goal.
Okay,
I agree. I think number 2 is very important, given the current anti-vax environment we're in.
yep,
I think we need more we can do about vaccination. Better.
right, and I know from working with Medfield this winter, when they were trying to figure out if they could just hold a vaccination clinic, there's a lot of things that need to be in place in order to do vaccination. I think there's 12 steps. And one of the first ones is a medical director. But then there's still a lot of work that needs to happen after that. And to put some concerted effort towards how to implement all of these things. And I think one of the questions is looking at cost, does the cost of this make sense? How do we implement this in a way that works with community budgets and all that stuff? All right, would anybody, does anybody want to remove one of the elected objectives? Would you remove assessment and surveillance? Would you remove it?
So you only want to have 2 objectives.
No, I just want to see if if we could have 3. My concern is we're short-staffed. And, we hire for inspection work, and then we try and get folks to do, can we build on their communication capacity and the like. So it's, I just don't want to fail you. But if communities are staffed, that means some of the work gets to happen with other people. Okay,
I mean, I think that
Yeah.
number 9, it's important, obviously, inventory management support.
Yep.
In a sense, it's something we do anyway.
right,
And I think vaccines are a little more important than inventory.
Yep.
Or if nothing else, somebody from the
No,
outside reading this,
I know.
it looks better.
Understood. Right. That's a very fair point, Ed, actually, to think about. Inventory is one of those kind of thanklessly important things.
Yeah.
But
There's a reason it's number 9.
but it's not identified with public health in the same way that vaccination.
Yes.
So, good. Daryl,
Hi, I think you might have addressed this, but there was some of the discussion I couldn't hear too
Sorry.
clearly. Is this one of those categories where we could select more than 2? Because I would have voiced my support for number 2 because it sounds
Yeah.
unanimous. It's going to add that Sherborne is also working towards that sort of thing
Yep.
as well.
yes, we can. We can choose as many as we want. And I think it's right. I think that it does make sense, pardon me, to add that. So, okay, so we're gonna have 3 objectives in each. I am gonna keep inventory management on just because we are doing it on the training hub
You
side,
have
so
to do it anyway.
we're
so-
doing it anyways, and I want us to get credit.
It's low hanging fruit.
Yeah, exactly, yeah, and it's part of our goal of trying to make sure that, we have good underpinnings for the program in general. Okay, all right, thank you. So that was, so we're done now with our work plan. We'll do a custom objective under surveillance, under sustainability, or a custom activity under sustainability. We'll have 3 for each. So now let's move to budget. Thank you. budget is, the same document that we were looking at same document we were looking at last week. Some changes to numbers to bring us into balance, reflecting our conversation. Column H is the proposed budget that we're looking at for this year. So I added a couple of things just to show where costs had changed. You can see on line 15, thanks Jen, our staff costs, and staff costs are the bulk of our budget. Our staff costs went down by $22,500. And that is for two reasons. We took the $30,000 from the other public health staff nurse position. We moved that out of the staff line and into expenses, and that's a proper accounting for that role, because we don't actually, staff are people that are paid by the host community, and you're on payroll for the host community, and that public health nurse position is not on our thing. So we've properly properly moved it out of staff costs. The reason why it's not a 1-for-1 of, the budget amount less was 30 is because there are regular annual cost of living increases and step increases for all staff. So there was a rise for everyone, and I apologize, I do not have printed versions of this. Jen, can we make it a coach bigger thing? Hello. And I know there was some question about, particularly on line 11 for the regional public health nurse role. There was people were asking about why there was a big jump there from 37 to 46. And that was in part because our proposed budget last year, we budgeted low for the position. And then this year so we're properly budgeted now for the cost of the nursing position, and that position gets a cost of living increase and a step increase as well. So that's why there's a bigger number. And then it's okay, Jen. Then the other section is other program costs, and so you see here we have I added the Dover nurse position, that agreement that we have with Dover. And that is 19,000 because we agreed that we would use a portion of CTCI funds to pay for that position. There's also, I added a modest $5,000 stipend. We don't really know how much a medical director will cost, but I said 5,000 was the most I could squeeze out this time for health communication, which is not just like flyers, but is mostly advertising costs for hiring new positions. I actually reduced the line item from 1,500 to 1,000 this year. That was maybe a little ambitious, but I needed to get us in balance. I reduced the cost of inspection supplies by $230,000. And membership fees remain the same. Those are membership fees for staff. We had no budget for nursing supplies last year, same for this year. I eliminated the $3,000 for purchasing a new laptop for staff, for shared services staff this year. Our cost for tech software went down slightly, the cost for relevant software went down. I reduced our budget for office supplies. Telecommunication remains the same. Travel is a big increase. We were sadly woefully under budgeted this year, and so we're budgeting now at what we expect the cost will be, and that has to do with travel to obviously to MHOA or to a MICA conference, but it's mileage reimbursements for going out to do inspections around town, and it's higher. So that is that cost. our, the agency admin cost is 10%, and that is, slightly lower this year. And I reduced our budget for training, from 10.5 to 6. Hopeful that, we're able to do some registration for folks with current year's money, so we won't have to spend as much this year. And we'll be creative in what we're able to send people to. That's largely the MHOA and NEHA workshops and conferences. So, I had to make a lot of cuts in our expenses in order to be able to meet the costs of the staff that we have, is basically how it went. And I'm within a penny, and I need Jen to help me fix the penny, because it's there's a funny little rounding thing. Okay. Questions about the budget?
I think your non-personnel line items are reasonable. And it stands to reason you've got a fixed bottom line budget. And as we progress through the years, salaries are naturally going to go up. So it has to come from someplace.
Questions? Carol?
I always have budget questions.
Yeah.
I think I should start at the bottom. So the 10% administrative support went down to 29. That is allowable. It's like 10 to 15% or so, I thought.
It's capped at 15, yes.
So is there detail on what that is? And the reason
No,
it ties into the other questions I have, such as
can I
nursing
take,
supply
Carol?
line is 0.
Carol?
Yeah,
I just want to answer your question about agency admin first before we get into detail. So agency admin, there is no detail, because that is essentially it's a payment to the host community, acknowledging the costs that they incur for hosting. So things like desks and printer access and the copier and the work that we get, the support that we get from town council for Needham, and it would be, if it was Dover that was hosting us, it would be the same, right? They would get this. There are costs that go along with hosting this arrangement. There's HR costs, there's work in arranging for job postings, and like there's the town council support, which has been significant this year, or well, last year was significant because of the AMA, this year with the Dover agreement, there's generally a cost, and that doesn't get billed to us. I think that captures the most of it, but so it is a pretty modest fee, and that goes to the community that is or agency that is hosting the program, and there is not an accounting for that. The DPH does not want to know. They just acknowledge that there are costs and that it will be allocated. So I just want to, if that's a complex
It's
one,
indirect.
yeah, it's indirect. It's
So-
a little complex, and I wanted to be clear about what that was before we get into the next. Go ahead.
So does it go to the town of Needham operating or Needham Public Health, which I hope, budget?
A little bit of both. So the state allows us to charge up to 15%.
Yeah,
We take less to make sure the math works.
Yep.
We do use some of it in Needham Public Health. Some of it goes to central admin. This year, HR wanted to have a diversity-related training. We paid for it out of the indirect. The town manager wanted to have a training for her department managers about how to run meetings effectively. We paid for it out of this admin. So it's basically money that, and with the town manager's office tells me to pay for.
Right.
And what will be the consequence of having a reduction?
I'm hoping to play up the reduction, so they're like, oh, no more ability to tap that. And, you know, maybe I can keep some of that, yeah, money for myself, but yeah, it would be nice. The year before, or no, 2 years before, we bought the Mum of a Pod here. We didn't have any space for any women who were breastfeeding or pumping, so we put the pod that's out there.
Right. It also pays for, if we can, we ask, we build, that's how we can have coffee and donuts. Because we can't buy food with our grant, so, you know.
Even
It
buys
says-
it and we reimburse me.
Basically.
So, okay, there,
Where are they today?
well,
I,
yes. Go ahead, Carol.
Me too.
so, thank you. The, other program costs?
Yeah.
What does that include?
So that is from lines,
All the expenses.
19
Yeah,
through, line 29. So that is the
the total.
Yep, that, so item number 2, you can see on line 18, it says other program costs, it's our expenses, it's our non-salary expenses. So
Perfect.
it's office
So-
supplies and contracts.
Great. Do all towns use the, software? The food, it was relevant, right? I was just wondering the
They do not, but shared services staff do. And one of the advantages, I think, to that is, that it does allow shared services staff ready access to prior inspections for the community, which is important for folks that aren't in your community all the time.
yeah.
So, I'm a little mixed on it, but I do know that there's benefit, especially with the shared inspectors. It's a conversation we're gonna have about how we use this inspection software for the coming, in the coming year. It is a discussion we're gonna need to have. How does it get used and what do we do? Because we won't be able to pay for it at all next year.
So thanks for that. It's the relevant food software. Does Medfield use it? And the reason why I'm asking is we're getting a new person and you're saying the amazing staff you have can look at our past inspections.
Medfield uses it. It was paid for this year. There were licenses paid for Medfield. And that cost includes Medfield licenses for this year. So we can only look at anything that's actually in the system. If it's not in the system, then we can't see it. But it's helpful for an inspector when they're going out to a site to be able to look in the system and see, okay, when was the last one? These were issues, these weren't, and that's the use of it.
So we, Medfield, have a license for it, and I don't want to put you on the spot, but did we use it so that the transition is a little easier when we have a person, or do you not want to say, or I don't want to put you in a
It
bad.
is my understanding that the contract inspector for Medfield does use that system. There were a couple instances where when looked in, and there were not records there, and that was something that we raised with Medfield, and they're following up. I have not had further information about it, but yes, it's absolutely something that was used, and
It's awesome for us to be able to advocate for that and to say it's funded for another year and we already had a license. Thank you. I think I only have 2 more. The fringe line, are all staff, is it like a percentage, the fringe, and then shared with the regional hub? So Jen and you,
as the assistant town manager, or deputy town manager of finance always likes to remind me, fringe is not a percentage, fringe is an actual cost.
Yeah.
Depending upon whether people are in a union or not, depending on whether they contribute to retirement and get a match for it, depending on if they have a family plan or a high deductible plan or whatever. We try to, because that's really hard to keep track of, we try to assign a percentage to it as an approximate. But no, it is actually a specific number depending on what employees hired and what they elect.
Right.
And fringe is for, it's the fringe cost for each of the staff positions that you see listed above. So we, basically, shared services is, you know, we're trying to be not a cost to Needham. So the grant pays for both the salaries and the fringe. Those are the costs of having employees.
Yep.
So
I'm just saying we're getting a deal because it says here 15.81%, and I'm not trying to nitpick.
Yeah.
I'm just saying there's a whole lot of percent out of the total, because that's how my grant works, and that's a good.
So, and I didn't calculate the percentage for, so that 15.81 is related to FY 25. I didn't calculate the percentage for FY 26. I just didn't, because I'm, you know, it's not a percentage, it's an actual cost. But yes, yeah, I mean, we're probably about 20% for fringe, and that pays for
Yeah.
us.
This is just, speaking of this, but 325,000.
Yep. Any other questions, Karen?
Yes, my last
Yep.
one. So you had said that the public health nurse from Dover goes into, you said consulting, so it's not there. Is that?
It is.
It is.
Line 19.
Okay.
Line 19 says consultant town of Dover. That is a agreement between the town of Needham as host agency
Mhm.
for us and the town of Dover. That is says, yes, we will pay X dollars, and it's a reimbursement agreement. So costs incurred by the town of Dover get invoiced to Needham, and then we reimburse a portion of it. And that's for 15 hours per week of the public health, of a public health nurse, which supports Sherburne and the other communities if there were to be a significant need.
Mhm. Did you, so maybe it was your email, it said that money's coming from, I thought you said like, it's been a tough week for me, CTC, or I don't know. I'm
Yeah,
not.
so, right, thank you. So the dollar amount that you see is not the total dollar amount for the cost of the 15 hours. The cost of the 15 hours is approximately 39,111, I think. And in our discussion last week, we agreed
Okay.
that to balance the budget, we would access CTCI funds to pay for a portion of that cost. The CTCI funds are, as you know, specific to, it's about disease control, it's related to case investigation, contact tracing, and so this is a consistent and appropriate use of those funds. And those dollars expire, so we're gonna use the dollars while we can. And that helps us be able to continue to buy a modest amount of office supplies and so forth for the budget. Yes.
Thank you. And I have one more question.
Yeah.
I feel badly that the nurse line says 0. Is telecommunication a fixed cost? Like with us in public health, I'm thinking, so there's probably 2 questions there. And that'll be my end.
Sorry, what? Oh. So, no, I know. So line 13, I understand what you're saying. So it says 0 in FY 26 because we're not funding it in that section of the budget.
Nursing
that's-
24, nursing supplies.
Oh, got it. Oh, sorry, you said supplies. Sorry, I heard nurse. Okay, sorry. Yeah, I mean, we did not have a need for supplies this year, and so I budgeted the same because there wasn't a need. That is, I mean, certainly that could change, but, part of it has to do with, you know, we can't really, we don't wanna, start buying supplies for the communities, you know, they've committed to having a public health nurse, they would be supplying their nurse. And our nurse didn't need equipment. I mean, if a need arose, we would have to have a conversation and see if there was money that we could move from another line item to pay for it. I wouldn't not.
We do also have CTCI money.
Right, right.
And we know that. I do think if there's a difference between what is submitted, which needs to be a balanced budget, versus what is the final.
Yes.
Because there will be savings along the way, whether that's
Yes.
because employees start late or because travel's less than anticipated or someone chooses not to go to a training.
Yeah.
So that's not to say we won't end up using any money on nurse supplies. It's just going into the year, the plan is zero because we have another funding source.
Right. I feel like that's an important line. I don't mean like buying things for each town. I'm thinking, you know, whatever Jen and the nurses may deem as important, not Kathy may know. And then telecommunication, are those fixed costs for phones and computers?
Yes.
That's for 3 staff, so we split it because we also have the training hub, that is cost for 3 of our staff. And then the other 3 are charged to the training hub. So that's the best way we can split it, you know, none of our staff for shared services are full-time employees. Most of them have some portion of their salary is paid for by the training hub. And, but we have to share costs too, we can't,
Yep.
it's not just salaries, so, that's fixed, that's, 3 phones and iPads, well, some iPads.
Thank you. Thank you
Yeah.
for all your work, Jen and Carrie.
Yes, I mean, thank you for acknowledging Jen, because took the words, that was big. This is all, having Jen here, has been a huge, I don't know, a huge success, it's wonderful to have Jen, it makes a big difference, for, you know, having someone who knows the systems and can do this, so that I can just go in and fiddle and play with the percentages and say, well, if I shave off 200 here, can we get this? It's a lot of work, and this is not by any means the only thing that Jen does for us, but it's a big piece of work, so thank you for acknowledging her, and thank you, Jen. Okay, and thank you, Carol, because, you know, budget stuff takes a lot of work, and so it's nice to kind of go through and have somebody kind of poke at it a little, and I want to be as transparent as possible, so. Anybody else have other questions about these? Yes, sorry, hey.
Well, this is more of a longer range question, but if we're being squeezed this much going from 25 to 26, what does the future hold for us?
So we'll have another, you know, staff increases, staff costs will continue to increase with the annual cost of living, whatever it is, and then staff increases.
And the PHE grant is
Not going to increase anytime soon. We had a 3-year contract and we're just finishing year 1. I do think that there's effort that needs to be made by people here and others to push for more funding from the state legislature, and to push ORH to recognize that as staff salary grows, these budgets are pretty lean. There are some options to increase our funding potentially in the future by adding a community. I think that's a trade-off, right? There's another community with more work to coordinate with, but we have economies of scale if you get big enough. I do think it becomes a question of what's the right sort of staffing plan for us. I don't love doing this, but, you know, do you think about if we don't have any, If we have trouble filling the environmental health agent role, do we go with 2 part-time inspectors instead of a full-time person? We save money on benefits that way, although I personally don't think that makes up for the fact that there's a lack of continuity between the 2 people.
Yeah.
So I think it's a situation we have to manage, basically.
So, for there to be more funding, there needs to be legislative action.
So all the funding, the state signed contracts with all the public health action and shared service groups for 3 years and included some renewal options. The money is funded with a combination of ARPA money that the state had, Department of Public Health specifically had, and FIG, Public Health Infrastructure Grant from CDC, where the state got the money up front. So it committed as much money as possible to these contracts and locked that in. Long-term, the state is looking to grow the amount of money that's in, by the state, I mean, the Department of Public Health is looking to grow the amount of money that's in the state budget for this. Because ARPA is going to be gone. FIG may or may not continue depending on what craziness happens at the federal level, but after these next 2 years, the funding is less certain. The legislature and the governor's office have been made aware of this. This is the first year where the governor, the House, and the Senate all recommended funding at the same level. In the past, one of them or another has recommended 0 or like half the funding and forced trading. So I think that's a positive thing, but we absolutely have to grow the amount of money in the state budget for public health. I don't know if you're familiar with, so Councils on Aging, they get an allocation, I think it's $12 or $14 per resident over 60 years of age. So I get a formula grant at my Aging Services Division that's $133,000 to help support programs over there. Obviously, we're talking potentially about a lot more than that, but the idea of the state funding aging services has been in place for a while. The state does grant programs like this, but it doesn't sort of give a subsidy to say, hey, you need to have funds to run health services as it does for education and libraries and senior centers and stuff like that. So I think one of the ultimate goals is to hopefully get a line in the state budget saying every cluster is going to get some amount of money every year to do services, and then they maybe add money if you're going to try to do extra work on the foundational public health services or more complicated sort of prevention and sort of overall health maintenance rather than sort of the regulatory like compliance in the field. It's a big question mark though.
Yeah. And that's part of the reason for doing the assessment on the foundational public health services is, so this is an agreed upon minimum level of services for adequate public health in a community. And so we're accepting that that is the minimum agreed upon level, and then we're also identifying where is every community in meeting that. And that provides information for us to start working on it, but it also provides information for the legislature of, oh, this is what needs to be present, this is where you ought to be headed.
And that's, sticker price is going to cause a lot of shock.
Yes, it is. It is going to be. Yeah.
But it's something we have to work up to as a state, and I think the only way we get there is by codifying. If you want to have, your health department involved in assuring the quality of water and providing maternal and child health services to reducing mortality and all of these other things, which I think all of us around the table believe in, it costs some money. And
Right.
The way we fund public health in the state is crazy.
Yep.
And I think the way we fund education is a little bit crazy too.
Yep. So there's, so all, we're getting. I'm telling my phone to stop talking to me.
When Nathaniel accidentally hits the buttons on my phone, once I said, "We're not talking to you." So now he does it every time. Siri, we're not talking to you. 3.5.
That's awesome. I love that. So there are a lot of pieces of data and got it right, there's a rhyme to the reason of all of this work that we're doing. It's useful for us, it's useful for the bigger picture as well. And I Daryl, I know you had your hand up, I saw you, and I see you too, Carol, but so Daryl?
All right, this is not a very deep question. Just as I was looking through the spreadsheets, I didn't see any equations underneath, which led me to believe that this isn't like some budget estimates where there's just a flat percentage of something applied or
Sorry,
anything
Daryl,
else. So
sorry, we can't quite hear you. Can you speak up a little?
okay, I'll give that a shot. Maybe I'm in a bad spot. All right,
It's a little clearer.
any better?
Yeah, it's a
Yeah.
little
A
clearer.
little bit. Okay. So, as I looked at the spreadsheet, I didn't see any equations embedded in any of the cells with like a flat percentage increase. So my assumption is that this is just a much more complicated budget that's driven by other things than more formulaic changes over time. So I just wanted to confirm that to make sure I was
Yes.
interpreting it right. Great.
Yes, you are. Yeah, no, this is not just a here increase by 20% or, you know, this is, you know, calculated exactly for each position. And then, you know, our best estimates for expenses based on past year spending and, what our costs are. Yes.
Okay.
Thank you. Carol, you had your hand up?
Yes, this isn't about our particular budget. It's more me trying to capture what Tim said. And I think he's still there. So basically from a local, yeah, there he is. Local advocacy on our part as well as state. So all these shared services agreements are funded through end of fiscal year June 30th, 2027.
Yes.
Correct.
Okay. And right now, there's no danger of like clawback from the feds because the ARPA money that is partially funding it is like in the state bank.
So actually, we think, you know, that you can never say never given the federal government, but the state made a conscious effort to push out the money and get it essentially off their books. So that if the federal government says you need to return X, Y, Z, they can sort of say, okay, well, we only have $10 and some change left. They encumbered or obligated, depending on what phrase you want to use, they reserved all of the money for these years into contracts, which takes it out of sort of the general pool of money that can be pulled back. So it was a smart decision. They've essentially already reserved all of the funding. They're not relying on new appropriations each year to fund the next 2 years. They funded this year and the 2 years that follow at the same time at the very beginning of the 3-year agreement.
Tangible. So I get that's good and it's all contracted, but the money's already been paid to Massachusetts.
Yes. Big
So
grant, they got 5 years of money up front. The ARPA money, the Department of Public Health got $200 million from the legislature.
Okay, so that's good. And then the other portion you said is paid through a line item in the state operating budget. I remember you and Denise working on it, like public health excellence.
So there is money in the state budget which supports the Office of Local and Regional Health and some of the training hubs and some of the other things. That money, if it will eventually replace, which we want, the ARPA money that's going away and the CDC FIG money, which, you know, is potentially subject to unpredictability at the federal level. That money in the state budget, which this year I think is 9.3 million, needs to grow substantially.
Yep.
To cover all of these things that we just talked about, it probably needs to be somewhere between 40 and 50 million a year.
Yep.
They're talking a lot about sustainability. We had a long coalition for local public health meeting about it. Cheryl and Mike were there.
Yep.
Looking at, you know, what are options? In addition to saying to legislation, you just need to appropriate more money, could there be by formula that,
Yep,
there's a tax on sugary drinks and 10% of that tax goes into a public health prevention fund and that's distributed by the State Department of Public Health to locals?
Yep.
Or is there an option to say, so the revolving funds are in, like, public health revolving funds or others are 53.5. Park and rec revolving funds are 53D. Could we potentially have a section of basically state accounting that creates sort of a preferential revolving fund that says, 50% of all the revenue from your public health permits and licenses and fees automatically goes, 50% to the general fund, 50% to this local fund, so that, if Needham took in $80,000, 40% would go to the general and 40% would go to this fund to help support public health operations. So they're looking at lots of sort of sustainability items,
yep,
which is smart because at some level, it's probably not going to be a single solution. It's probably going to be a little bit of this and a little bit of that. We're going to try to cobble everything together.
yep. I liked what you said about, I never heard you talk about the $12 for anyone over 60 goes, the state has this formula
It's the
and
greatest grant for people who manage grants. There are like essentially no requirements on the grant, and the reporting is basically like write a one-page memo at the end of the year telling us what you did. It's like,
Oh my God.
I don't know. There are a lot of senior needs, but it's the type of thing where we could get like an aging services race car, basically. There's no restrictions on the grant.
I think that's a really, what you said is if I'm talking to someone can't say to me, oh, well, we do fund public health I would say it would be, and our goal is to work towards a formula grant where it's equitable
Yeah.
per person as the aging, does, so that each town, because public health excellence line in the state operating budget could go away, right?
It could.
Right.
I do think that, the Commissioner of Public Health is very on board with understanding this has to grow, that all of the work we've been trying to do, and it's a little bit like education, and the legislature really didn't like the fact that the quality of the student's education depended almost entirely on the zip code in which that student resided. Now, it still does to a large extent, but the state has put a ton of money into subsidizing school districts, with a little bit of money going to the wealthiest districts and a lot of money going to the districts that have the greatest need. But the idea we want from public health is essentially the same. We don't want, because you live in Lawrence, you haven't had your restaurants inspected in 2 years. You should not be more likely to get food poisoning because you live in Lawrence than if you lived in Dover or Sherburne or Needham or Medfield, right? That the idea is that the quality of your public health services shouldn't vary by zip code. And that, is all about the idea of equity, that we want to treat people fairly.
Thank you for that.
Yeah, I would stay away until they actually start inspecting.
Yeah. Thank you for raising those things, and thank you, Tim. I mean, this is part of the communications work that we're talking about in this year's work plan I see it as building a groundswell, right? It's building a awareness that then says, oh, and these are the things that we want to be funded, that we need to be funded. They are right now funded through this line item, and we're pursuing how do we do it. So we need to make our services visible and make ourselves visible, and then say, and for us, there's a cost, which is right now a kind of a gift. So yes, we're laying the groundwork for good advocacy, and we're going to have to do some more active advocacy as time goes on. So a great way to kind of wrap the thing. That's the big picture goal we're working towards. Okay. Any other questions about budget or work plan? Anybody feel like we have covered it and everyone's comfortable with the changes we talked about on work plan? Okay. We did not post for a vote today, so what I'm gonna do is I'm taking all these comments and I am, incorporating them. I will submit it, and then I will ask that you vote in July on this, we'll have the approved budget from DPH and work plan from DPH, and I'll ask you to, approve that. And that will be our codified thing. But what I take from this is that people understand what went into the budget, understand the decisions that we've made about it, understand and agree with the choices we've made for the work plan. And I have permission, Jen and I have permission to move forward, make these submissions, and then we'll bring you back and approve budget and work plan, in July. Speaking of July, so we have another meeting, strategic planning meeting on the 26th of June. That will be our last strategic planning meeting, then we'll go through the report with us all. And then we have, the months of July and August. And my question is, do folks want to meet in July and August, or would people like to have one meeting? Because I know summer can be, busy, with travel plans and the like. We typically meet monthly. Is there interest in perhaps having just one meeting in July, and then reconvening in September?
I think that whatever week meeting in the summer is, July is probably just as good. I might have to be there by Zoom for the British family week.
Okay, yeah. So yeah, that meeting in July would be the last Tuesday, the fourth Tuesday of the month. Is that, so if you're willing, we could meet in July, and then we would skip the meeting in August, which is the fourth Tuesday in August, and then we would meet again at the end of September.
And I assume you think we don't have, that we wouldn't be doing a disservice to our group by not meeting in August, that there's not, once we've got this voted on, we're off
Yes.
the hook a little bit.
Yes, and, you know, I guess I would do like a health director would do and say, if there was some kind of business that changed that, so I thought we really have to meet, then I would ask you all if we could meet on that August meeting. But, that I think we're in good shape, and that missing month would be all right. So, Carol, I see your hand up.
Yeah, just to clarify, so you'd meet in July 22nd, but not again till the end of September? So like an 8-week?
Correct.
Kathy's our main person, so
And
I'll let her.
We could move the meeting date if, you know, we could move the September meeting date and have it earlier in September if folks are concerned about the length of time for the gap. That's fine too. I see your head nodding, Kathy. Does that mean you think it might be good to make the September meeting a little earlier?
Yeah, I'm open to either. I know we have one meeting in Medfield that is on a Thursday, so I just have to check that date, but I'm actually available either way.
Daryl?
I would look at it from, at the meeting in July, plan not to have a meeting in August. And then September might depend on what has come up in between. Because I feel like some things we can't anticipate, heaven forbid,
Right,
another pandemic or something, so.
Oh, don't speak those things into the universe. But you're right, I agree, but yes, we don't know what could happen. Okay, all right, so we'll meet again June 26th. I will be leaving for the beginning of the meeting, and then I'll have to excuse myself, I have a medical thing I need to take care of. But Jen and BMU will be able to take you all through. Then we'll meet again on July 22nd. At that time, I'll have the approved budget and, you know, the information from TPH, and those are the times that I'll see you. Unless anybody wants to see me anytime sooner. You know where to find me. You know how to find me. You have all my digits and, okay, all right, so great work. Thank you all for the feedback. I really appreciate it. I would be interested if anyone wanted to make a motion to adjourn.
So moved.
I have a motion from Kate Peterson
I'll
to
second.
adjourn and a second from Ed Cosgrove, Needham, and now do a roll call vote. Dover,
Yes.
Medfield,
Yes.
Needham,
Yes.
Sherburne.
Yes.
Great, we are adjourned. Thank you all. I know this was.
Thank you, Carrie and Jen and
Happy
Tim
summer.
and Ed and all of you. Thank you.